Hi, everyone. Welcome so much. Thank you for taking time out of your Aspen schedule and out of your Sunday to join us. My name is Nicole. I'm with Envara Health. I'll be maintaining and facilitating the chat today, so please use the chat feature for any questions that you have, and I'll relay them to Dr. Stallings. We will be recording this session. It's my pleasure to introduce Dr. Virginia Stallings, Principal Clinical Investigator of the studies we'll be reviewing today. Dr. Stallings?
Hello, everybody. We're recording here in Philadelphia, and again, very much welcome you to joining us. I wish we could be together someplace beautiful and warm, but at least we're officially in spring, and I think that will be good for all of us. I'm going to ask to turn off the video of me during this to sort of save bandwidth, and then we'll turn it back on for the question and answer session. So here we go. Here we go. There we go. So just to show the disclosure slide, the vast majority of the time of the session we'll be talking about the CF randomized controlled trial, which was funded by the NIH. And also to mention that when I did the trial, we were using the study-specific supplement, and now it's Envara Health that has really produced the commercial product, and I continue to be an advisor for them. So the next, sorry, that's me. The next slide is just a bit of an overview. Again, the main thing we'll be talking about is the background on this lipid matrix technology and the clinical findings from the study. But then we'll spend a little bit of time on now the clinical indications of the product, and a little bit at the end on how to, that we have both oral and tube feeding experience. Now, fortunately, for this meeting, I don't have to talk very much about us appreciating the degree of malnutrition in both hospitalized and outpatients with many, many chronic diseases, and that we now have evidence that certainly shows that improving nutritional status of our patients, both adults and children, improves outcomes and quality of life. And that, of course, is a lot of why we really focus on continuing to improve the clinical spectrum. Now, as I mentioned,
Richie, we're getting some feedback. Can you check the line and see if the participants are muted, please?
I just did, and I muted the person that was giving us the feedback. I apologize for the interruption.
Thank you so much.
Okay, thanks everybody. So again, the data I'm presenting really are from a CF study, but I show this quote because I like to use it to really remind us of how long we had to gather the scientific evidence to really prove with a great deal of confidence the relationship of nutritional status and improving the outcomes in CF. And now that certainly goes to general clinical outcomes and to longevity. Now, for those of us working in the field of CF, we have some really very special data sets and experiences that help guide this. One is the CF Foundation Patient Registry. And here I wanted to show you some of the data in changes in nutritional status in children and adults, and how we got there. So if you look at this, you'll see beginning in 2004 up through the most recent data, which is 2019, that looking at weight percentiles in children, we were really able to cut, using that as the benchmark, the degree of malnutrition in half, from going to almost 20% of the patients down to 10. We're doing fairly well with height, but I always like to remind us that height in pediatrics is a trailing indicator. And you can see we've not made nearly so much progress in height. And we've got to continue to focus on optimizing height to the genetic potential. Now, the question in CF is, it's one of the It's one of the places where the registered dietitian or clinical nutritionist is an integral part of the team and has been for decades. So what you see here is we've achieved these improvements by using supplemental feeding. 10% of patients across the country are usually on tube feedings. And in addition to that, we have another 40+% that are routinely getting supplemental oral feedings. So in this particular disease, with pancreatic insufficiency driving the malabsorption and poor nutritional status, we've made real improvements, but it really is based on using what we think of in Aspen as traditional nutrition support methods. And then the other item that I circled, now we're delighted to say that more than half of the patients with CF in the US are adults. The age of survival has increased dramatically over the last years. And so CF is really an adult disease, not just a pediatric disease. And moving into adult CF care centers with, again, the dietitian being a clinical member is part of what we're trying to now face in a different way. Here, though, I'm showing that almost half of the patients who are adults do not meet the BMI goals. So we still have a good ways to go. And the last note on this slide is just to remind you, again, as patients with CF are surviving longer, we're getting more and more CF-related diabetes. And this does then complicate both the nutritional and general care. So the takeaway here is about 45% of the patients with CF are on nutritional care at any given time. So the next slide goes now to the beginning of the background of really the pathophysiology and the clinical trial we conducted. So in CF, about 85% of the patients in the US and really around the world have mutations that cause pancreatic insufficiency. And with that, then the first line of treatment is using pancreatic enzyme replacement therapy. There are a number of products that are FDA approved and do really a very good job. But even with this modern medication, the enzyme replacement medicines, most patients are still having some malabsorption. So it was in the face of this that Dr. David Yasser, who is the inventor of what was called Limixorb or LXS as the study product, and today is called Encala as the commercial product. Dr. Yasser was very focused on trying to improve dietary fat absorption. And with that, developed this new molecular structure that is really based on lysophosphatidyl and fatty acids, particularly the two essential fatty acids. And he was driven to really address this persistent malabsorption. And that's when he and I worked together for the clinical trial. And the key take home really is the product is both lipase and bile acid independent. I think the way that, as I've come to think of it, this molecular structure really acts as its own micelle. And so you get very highly efficient absorption of the fat that comes from this. Now, the study, the full study involved 110 children and adolescents with CF and pancreatic insufficiency. They came from 10 different CF centers, mostly on the East Coast of the US. And they all traveled to Philadelphia to participate in what was really a very complex clinical and metabolic study. The primary outcome was that we were able to show, using the coefficient of fat absorption method, the CFA, that there was an improvement for the group, a mean improvement from 82% up to 88% absorption. And this was following the group over 12 months of treatment in the trial. What I want to spend more of the time on now is a secondary analysis that we conducted and published just a year or so ago, where we came back and wanted to ask the question about those patients with the more severe malabsorption at the beginning of the study using the baseline CFA. Did they show greater improvements? And particularly, we were interested in growth, the essential fatty acid status, and of course, the CFA after treatment. So for this analysis, we looked at the changes between baseline and 3 months. I hadn't mentioned the ages, but the subjects were 5 to 17 when they enrolled. And the study was designed around the commitment to having a very active placebo. And what I mean by this is the placebo contained the same number of calories and the same grams of fat as the Limixorb or Encala product did. So that we were really trying to test not just delivering more calories or more fat, but to test to see if the absorption were really greater. And did that translate into important clinical outcomes, such as the weight and height and BMI? And in this study, and many of our studies with children, we use the Z-score approach. And then looking at plasma fatty acids, the CFA in the stool that was collected over 3 days. So again, to emphasize, what we'll be looking at is the subgroup that had a CFA of less than 88%, which was the median for the group. So those are the ones who had lower CFA, which really means higher dietary fat loss. So to walk through the couple of data elements here, this first slide is to focus on, again, the CFA. And this was our primary outcome in part because it is the test that the FDA uses when they're looking to approve or evaluate the pancreatic enzyme replacement medicines. So it's very much considered a gold standard for clinical research and for FDA approval. However, I'm the first to say that this is not a test that's done in routine clinical care. So the evidence we have here really helps, fill a different kind of knowledge base than we get in clinical practice. So if you look at the panel on the left, this is from all patients, the 110 subjects that I mentioned. And if you look at the baseline, you can see that the two groups, the active placebo and the Encala, were not different at baseline. So we're always very happy to learn that randomization really did work. So as we brought in all of the subjects, they were similarly randomized to the two groups. And looking at that, all patients, you see that the CFA did not really change in the light blue, which is the active placebo, and the darker blue, which is the Encala, increased from 82 to 88% and was statistically significant. So for the newer analysis, the one we'll spend a bit more time on, this is with the patients who were in the high risk, greater need group. And here again, you see at baseline, there's actually more of a numerical difference, but it was not statistically significant. So we also have randomization still holding. And you see certainly a more dramatic change over the 3 months, where those on the placebo stayed about the same, 73 to 71, and the ones on the Encala went from 79 up to 86. And again, quite statistically significant. And I'll remind you at this point, again, that all patients on the trial were known to be pancreatic insufficient, and they were all being treated with PERT, the pancreatic enzyme replacement therapy. And all of that was managed by the home CF center. That was not a part of the trial. So you see here that we did see a greater improvement on the patients with the greater need. Now, the next data set was to look at growth. And certainly when we're caring for children and adolescents and even into young adulthood with patients living with CF, growth is an important part of the story. So you see here the changes displayed from baseline to 3 months in Z-scores. And then the delta is the difference between those two measurements, and then the p-value for each of them. So for weight, you see that over the 3 months, we had an improvement of plus 0.17 Z-scores, which was highly significant. And the other, to me, somewhat remarkable and very powerful thing was we also saw an increase in height in just the 3 months. And that was the 0.06 Z-score change. And again, highly significant. And of course, if your weight and your height improve, then your BMI, which is directly derived from those two things, also improved. And we saw a BMI change of 0.2. So in the pediatric sense, this very much what represents what we think of as catch-up growth. In other words, the children now were gaining weight and height at a greater velocity than healthy kids of the same age and sex. And that's really the indication of effectiveness on the growth parameters. And then the next data set that I wanted to share with you was those that related to the essential fatty acids. And we did collect data on a whole panel of fatty acids. But here I wanted to really highlight the two essential fatty acids, the linoleic and then the alpha-linolenic acid, as you see on the top panel. And here, the placebo is in yellow and the Encala in blue. And you could see for the two essential fatty acids that we had an improvement of 20% in linoleic acid that was significant, and an improvement of greater than 50% for the alpha-linolenic. I did add the gamma linolenic acid here because many people are interested in understanding what's happening to the fatty acids that we think have an association with either increased inflammation or decreased inflammation. And the gamma is one of the ones that is associated with decreasing the inflammatory status in humans and in many animal models. And then the panel at the bottom, just to show you, we got this result by providing these two essential fatty acids as a core component of the molecule. In my study, patients, the younger group got 2 doses, the older group got 3. So thinking of the younger school-age kids versus the adolescents. And you can see here the linoleic acid grams that would be delivered in 2 doses, 6, and in 3 doses, 9. And what I put over on the right was the DRI recommendations just for 2 different subgroups to show you that if you were using, either 2 or 3 doses per day, you would be making a very nice contribution to the daily intake of that fatty acid. And if you go to the ALA, because our dietary requirement is really a good bit lower, that using the 2 or 3 doses, again, would be a contribution similar to what the recommendation would be for healthy people. Now in CF, we have, again, a long history of understanding that there are essential fatty acid abnormalities in the disease. We believe most of them come from this chronic malabsorption. And so addressing the fatty acid status in addition to the calories was one of the key design ideas that Dr. Yerser and we had trying to move this forward. Okay, so the other, if you will, nutrient or the other component of the structured lipid that I wanted to mention was choline. And as I said, this really was made up of lysophosphatidyl-choline. So it is very naturally choline rich. Choline is not a nutrient that probably gets as much attention as it should, except in some settings. But it is also a nutrient that's known to have abnormal metabolism and status in CF. But here I wanted to go back just to remind us that choline is really an important part of every cell membrane because it's part of the phospholipid structures. And also that choline is, of course, part of acetylcholine and that whole class of neurotransmitters. Choline also contributes to the 1-carbon metabolic pathways. So that is complex and easily modified with choline deficiency. And then the phosphatidylcholine is a real part of the overall lipid transport that's been so well studied. In humans, at the bottom of the slide, just to mention, there is a well-defined deficiency syndrome, and even one that you might even think of suboptimal status rather than really pure deficiency. And when it's been looked at, one of the first things you see is an increase in liver enzymes, so liver inflammation, and then you'd see the development of fatty liver and the hepatic steatosis profile. And I think we've all become aware that NASH, the non-alcoholic liver disease, is really epidemic in the US now. And it's something that certainly as physicians and many lay people are beginning to learn about, sometimes associated with obesity, but sometimes not at all associated with obesity. The other things with choline deficiency is it does alter essential fatty acid delivery to the peripheral tissues, particularly to muscle tissue, and it's related to muscle abnormalities. And you do see an actual depletion in the concentration of acetylcholine with the deficiency. And just to pause for a moment, because thinking of the breadth of all of us gathering at an ASPEN meeting, there is particular importance of choline and nutritional status for young women who are planning to become pregnant or who are pregnant and breastfeeding. And this was just a nice diagram that helps take it through in the blue box about, yes, as I mentioned, it has almost ubiquitous metabolic responsibilities. But then some of those go directly to the issue of having a healthy placenta and being able to transport nutrients effectively. And again, some mention of creating an anti-inflammatory environment for the placenta and the fetus. In pediatrics, we learned a bit more about this with some of the animal models and then in children or infants, that the neurodevelopmental outcomes are very clear now, and that there are a number of methods that go to documenting this. I think for many of us, the visual acuity studies that were done in neonates were sort of the wake-up call. And then lastly, over on the right, the whole field of epigenetics and how what's happening with choline metabolism for the mother in the fetus, and then actually in the newborn. So it is a nutrient that I think we're going to know more and more about and be able to think more about, but particularly in settings of pregnancy and lactation. So I wanted to show this because choline is one of those nutrients that has an adequate intake recommendation rather than an RDA. And this is a slide that shows in the purple bars what that level would be, choline intake milligrams per day. And then in the little blue bars with the different stages of life showing what the typical intake is now using data from fairly recent NHANES, so that you can see, other than for children, the intake across the scale of young adults through aging, and again, particularly in pregnancy and lactation, is low and needs to be addressed. Okay, so back to choline and CF, really based on an amazing set of studies from Sheila Ennis, who was in Canada and very much focused on choline as her laboratory's major initiatives for a number of years. And she and her colleagues showed through a number of studies that choline, suboptimal choline status was very common in children and adults with CF. And in fact, looking at the plasma LPC, the lysophosphatidyl and PC, the phosphatidylcholine, was low. And it wasn't low just compared to population. It was low compared to their siblings, eating the same diet, living in the same household, and documented changes certainly in the plasma, and also showed increased losses of excretion of those two compounds in the stool. And then went on in a short-term supplementation study to show that if you supplemented children with CF and pancreatic insufficiency, that you could get some normalization, and particularly the methionine homocysteine pathway, which goes back to the one carbon metabolism. Another study that came out more recently was, again, a correlation study. If you look at the panels over on the left, FEV1 is the lung function measurement that we frequently use in CF to really determine how serious the lung disease is. And here you can see the correlation between the FEV1, where having a higher number is good, and the choline concentration, showing that there is a very strong correlation between choline status in the blood and lung function. The one in the bottom on that same side, the choline slide, is using IL-6, interleukin-6 concentrations. And the point is here, and IL-6 is one of the commonly used measurements for systemic inflammation. So here you see the dark line showing the correlation that the higher your choline, the lower your markers of systemic inflammation using IL-6. So in the study that I did, this shows you the calories. As I mentioned, we mostly used either 2 doses or 3 doses, so providing about 300 or 450 calories per day. And you can see the makeup of both of the products. But I wanted to call your attention here to the choline concentration that you see again. And in the higher doses, in the 2 and 3 doses, we would have been giving quite a nice choline supplement with the Limixor. The placebo did not have, was not particularly enriched in choline, but it had some. And then the note at the bottom is just to remind me to say again that the product I used in the clinical trial has been reformulated a little bit for improvements, mostly to take out the sugar and the wheat flour that was in the original product. And the product that is now available would have 240 milligrams of choline per dose. So the data that came out of it, just two bits to share. One, what happened in the plasma and stool, and then a little bit of information on the MRS study that we did of the liver in calf. So here you see that when we looked at our baseline data using a commonly acceptable cutoff for poor choline status, almost half of the patients had low choline status at baseline. Then once they came on study, those that were randomized to Limixorb had an improvement in their plasma choline, also an improvement in the betaine, which is the highly related other metabolic compound that choline goes to. And in looking at all the different species of water-soluble cholines, so we were seeing improvements across the board. And then to mention the fecal excretion. And again, as Dr. Ennis had found, there had been increased fecal losses at baseline that were improved. And that in our study, when we looked at the CFA, we said we did, so again, looking at a measurement of fat absorption, as we improved the fat absorption, we saw an improvement in choline and also less fecal excretion. So suggesting that the choline was being provided by the supplement and improving blood levels and also decreasing the malabsorption and the loss through the stool. Okay. So to summarize all of that, then the structured lipid matrix is really the scientific basis, and it was designed primarily to improve dietary fat absorption. And also, not speaking about it today, we have data showing that it improves some of the fat-soluble vitamin absorption. And I just mentioned a good bit about how it is both choline and essential fatty acid rich. So it is a medical food by the FDA definitions, and all of the ingredients that go into making up the commercial Encala are on the GRAS list, so generally recognized as safe. And then looking over on the right, when we are talking both with patients and dietitians trying to explain more about this, the key points really are that it is a very easily absorbed, healthy fat, calorie-rich powder. It was designed for long-term use. From the study, we had 12 months and actually had a subgroup that went on for 18 months. It's designed to be incorporated into the daily diet, both solid foods and liquids, smoothies, all sorts of things. It is plant-based, as all of the ingredients are plant-based. So it does go to those healthy items. And as I mentioned, it's now gluten-free. Because the product I use, part of the additives that were used to keep the fats in powder were wheat flour. So happy to say it's now gluten-free and milk-free and made from non-GMO ingredients. Here's the nutrition fact label, just that it's 2 scoops is a dose. That's 18.4 grams of powder. In my study, we used 32 grams of powder. So again, an improvement in the bulk of what is needed, that it delivers then about 100 calories. It's based on the 6 grams of fat. And I had mentioned the choline now is at 240 milligrams. So to shift really then to the broader indications for Encala, clearly our early focus was CF, but we rapidly came to understand this could really help in nutritional therapy in a number of settings. So as I've come to think about it, I really think of it in, if you will, these 4 buckets. Anything that's exocrine pancreatic insufficiency-based fat malabsorption, and I'll show you the full list of those diseases, but that really comes out of our work with CF, and then with chronic pancreatitis being the other big disease. But because we started with pancreatic insufficiency, this also should have a role to play in any other setting with fat malabsorption, because this really doesn't have to do with the dependency on lipase or really on bile acids. So that gets you into thinking about growth faltering in infants and children, also really very broadly, any disease-related unintended weight loss in children and adults. So here's my working list of pancreatic insufficiency diseases, and certainly CF and chronic pancreatitis and pancreatic cancer are the ones we think of most commonly. But with us being an ASPEN audience, I also wanted to bring up that moderate and severe protein calorie malnutrition is another condition where you have temporary, not usually long-term persistent, but you have damage to the pancreas and decrease in lipase. And then certainly in frail elderly, we know that over time the pancreatic output does decrease, and there are some people who in their aging process might benefit because of the pancreatic component. Now, I wanted to put up again these rare diseases in pediatrics. Each of these diseases has a subspecialty home, and it's important that, whether it's the hematologist taking care of Schwachman-Diamond or the endocrinologist with Johansson Blizzard, that they also recall that there is a high risk for pancreatic disease in each of these conditions. Back to more general things, because this molecule acts as its own micelle, it's also bile acid independent. So it's likely, again, not part of the study that I did, because if any of my CF patients had serious liver disease, they would have been excluded from this particular clinical trial. But there is growing interest in looking at how this might be helpful in people with malnutrition and various liver diseases. And also the other two that some early experience has been for working in some patients with short gut. This seems to improve weight gain and GI symptoms, and also some with motility disorders, which again are a very ill-defined heterogeneous group of patients. So for the general nutrition support, the dose is 100 calories, about 18 grams of powder. When the product first came out, because we had so little experience in infants and very young children, it was suggested that this be used really once a patient or a child begins to consume table foods, family foods. Although there is work being done right now with different groups to do testing for solid foods in infant formulas. I mentioned dose in the study. We use 2 and 3 doses a day. And in general, this has been what the feedback is, that you can move from some of the liquid supplements, which tend to replace meals, to adding this powder to help support more typical family foods. And then also we have some experience in using with tube feeding. So let me show you this. And this comes out about 10% of the subjects on my study chose and brought to us the idea of using it with their tube feeding, and were successful. And again, recently evaluated independently with the commercial formulation, or these 2 general recommendations, that being able to use Encala either mixed with water, about 4 ounces, and use it as a flush or a bolus, or if you mix it with the actual formula, to use about 8 ounces. The one thing, and then, there are various ways of mixing it, either by hand, or so many people now use quick blenders for that. So 2 important things related to tube feeding. Encala is not recommended for using with the full enteral pump system. And again, all of you probably know all additives for tube feeding formulas are supposed to only be used for a limited period of time. So the recommendation right now isn't to put this all in with the enteral feeding bag, but to use it as the pre-post bolus. And in CF, there's another new nutrition support product called Reliazorb, which is a cassette that has beads that have lipase on them. And just to mention, in case some of you are thinking about your CF patients, you do not want to put the Encala above the Reliazorb cartridge. One, it doesn't need the lipase for digestion, and you would be wasting some of the capacity for that product. So in summary, there's a new structured lipid technology. It has safety and efficacy evidence based on a randomized trial in CF, which is generalizable to, we think, a number of other diseases. The key take home is with its molecular structure, it's lipase and bile acid independent, really improves absorption, can be considered for pancreatic and non-pancreatic diseases, and that it is very calorically dense. And we have evidence of it supporting growth faltering. And then lastly, we have some experience, both oral, but also with tube feeding. So just wanted to put this up to their websites for both the company and for Encala as the product, and all sorts of things that you can learn about on the website. So I will close there. We have a